Hello, everyone. I'm so thankful to be here. It's really, really an honor. Let me get my slides up. And I do want to note that about a decade ago, Autism Science Foundation was the first organization to give me my first grant as a PI. And let me tell you, that first grant is a really, really important stepping stone. It's really kind of the hurdle you have to cross in order to get the other grants, so it really made a huge difference in launching this research program. The title of this talk is Addressing the Challenges of Anxiety and Autism. So I thought I'd begin by using the words of autistic individuals and their family members to illustrate those challenges for you. And in general, I just want to point out that the talk is actually centered around quotes pulled from qualitative research studies, which are research studies that really focus on highlighting the perspectives and accounts of autistic individuals and those that care for them, to illustrate key findings from the broader quantitative research literature and their implications. Sometimes anxiety can build up on itself like a brick on an accelerator pedal. Whenever you make a mistake due to anxiety, you become more anxious. It's just something that keeps being in your head, and you can't get it out, and you can't focus on other things. Anxiety disorders differ from anxiety, which is an emotion we all experience and which typically serves an adaptive function. Anxiety helps us stay safe, plan for the future, get things done. Anxiety disorders occur when this typically adaptive, informative emotional system, instead of helping us navigate our lives, becomes all-encompassing. Anxiety disorders dominate and deplete our attention as opposed to directing it. Research suggests that anxiety disorders are associated with specific additional difficulties for autistic individuals, such as increased depression and self-injury, gastrointestinal illnesses, sleep problem, reduced quality of life, a reduced willingness to interact socially, and increased family stress. He shuts himself down and he goes to bed. He'll be in that room for 15 hours. Children can become so overwhelmed and depleted by their anxiety that they withdraw from the world for extended periods. A mother whose son has a severe dog phobia describes, "I am risk assessing where it's appropriate to go and what is safe. I'm a single parent, so I have to really think, where can we go, where can we manage, and what's safe? As a part of that risk assessment, I think, will there be any dogs? So every time I go out, I consider the difficulties that may arise to minimize the anxiety. Every trip out the door requires an accounting of risks, feasibility, safety." Anxiety disorders can make it hard not only for autistic individuals, but also their families to navigate the world around them and to complete daily tasks. There's the parable of the little engine that could. It's a little engine that willed itself over a tall hillside carrying a large train by saying, "I think I can, I think I can, I think I can." What makes anxiety disorders particularly dangerous and debilitating is that when you have an anxiety disorder, you look at a challenge and you think, "I can't." You not only have to deal with the hill, but you have to deal with the doubt. There are many challenges in life, and this is likely particularly true for autistic individuals, yet there's a distinction between the challenge itself and the psychological distress and suffering that often accompanies it and exacerbates it. Reducing anxiety is a way to remove that additional layer of difficulty and thus to make a huge difference in the lives of people on the spectrum. We may not be able to take away all the challenges, but we can work on building resilience rather than suffering in the face of them. And I also just want to note that I see anxiety disorders as a problem with a lot of promise. So across clinical trials, of which there are now over a dozen, we see that 58 to 71% of autistic youth will experience a remission of their primary anxiety disorder following a course of cognitive behavioral therapy. Both group and individual programs have been supported. Tailored approaches, that is CBT, that's been adaptive specifically for autistic youth, offer some advantages, but research is also clear that standard CBT can be of help. Moreover, the research base is growing, and it's focusing on expanding access. So emerging work supports the efficacy of CBT for adults. It supports behavioral and modified CBT approaches to treat anxiety in autistic individuals that also have co-occurring intellectual disability. It's focusing on school-based and step care programs that aim to get interventions to people expediently and cost-effectively. but this is also all prelude, as the main purpose of this talk is to convince you that to address the challenge of anxiety and autism to be most effective, we must begin by better recognizing and understanding the diverse ways that anxiety is experienced and expressed by autistic individuals. How we define and assess anxiety disorders in autistic individuals, how we draw the lines regarding what to conceptualize as autism versus anxiety, has huge implications for estimating the size and characteristics of this public health risk and to identify who's in need and likely to benefit from available treatments. Yet the process of drawing those boundaries is not so simple. A mother describes, sometimes it's very difficult to understand whether it's an autistic behavior or whether it's a behavior caused by anxiety or both. And my hunch is that most expert clinicians would tell you the exact same thing. There are several reasons why drawing the lines or making these distinctions is so challenging. And one reason goes back to how we differentiate adaptive anxiety from anxiety disorder. Part of how we do this is by evaluating how realistic or protective an individual's fears are. And what we see in autism is many reasons why having more fears makes a lot of sense. Richard, an autistic adult, discusses his social anxiety. He worries, does that person like me? This is a quintessential social anxiety fear. But Richard also recounts, others were not interested in me. The other children ignored me. Many times people on the spectrum are worried about social encounters because they should be worried, because they are actively being bullied or more subtly, politely, but still painfully excluded. In such cases, such worries may be protective. This quote illustrates how important it is to think carefully about how realistic and adaptive a worry is before pathologizing it, and why this can get complicated quickly when autism is also in play. Other key reasons why differentiating anxiety disorders and autism can be challenging are the overlap of autism and anxiety symptoms and the distinct ways that autistic individuals may experience and express anxiety. This is a description of Donald written by his father and printed as part of Leo Kanner's original characterization of autism in 1943. This summer, we brought him to a playground slide. When other children were sliding on it, he would not get about it. He was horror-struck. The next morning, when nobody was present, however, he walked out, climbed the ladder, and slid down, and has slid down it frequently since, but slides only when no other child is present to join him. Donald's father uses the word horror-struck. But what exactly is Donald afraid of? Perhaps he's afraid the other kids will tease or dislike him. Alternatively, perhaps Donald's not attuned to or concerned with his peers' judgments, but he does fear how unpredictable they are. Perhaps his worries arise from his struggles to know what they want and what they're going to do. Maybe he's not scared at all. He's just distressed because they're getting in his way. This quote illustrates how social avoidance like Donald's might reflect a feature of autism, a symptom of anxiety, or some combination of the two. Here are some more recent illustrations. Audrey, I get anxious in social situations as I don't see emotions in people until they get to a 10, and then it's an explosion, and I don't know when it's going to happen. A parking lot can be terrifying because of all the headlights. A mother describes her son's anxiety around changes in routine. At the beginning of a term, they dropped the first period of the first day. M couldn't sleep that weekend. He has to bring the books in for the period even though he doesn't have it. In all these examples, we see key features of autism highlighted: social communication difficulties, sensory sensitivities, a desire for sameness. But we also see anxieties layered on top. It's not just that M refuses to accept a change in his routine, it's that he was worrying all weekend, unable to sleep because he knew it was coming. A growing body of research is exploring the possibility that anxiety may come in different varieties in autism, both similar and distinct from the anxieties expressed by autistic youth or non-autistic youth. And it's our working hypothesis that these distinct expressions may reflect anxiety influenced by the different ways that autistic individuals perceive and experience the world. So across several research studies with community samples, we've endeavored to carefully characterize anxiety disorders in autistic youth using an adapted clinical interview to reliably differentiate between autism and anxiety-related behaviors and to capture distinct expressions of anxiety so we can learn more about them. What we see in these studies is that 30 to 40% of autistic children do not meet criteria for any anxiety disorders. This is important because sometimes it can be easy to think that all kids with autism have anxiety disorders, but that's not actually the case. About 50% of autistic youth met criteria for traditional anxiety disorders, that is, anxiety disorders similar to those seen in autistic youth and cataloged by the DSM. 50% or more of kids with traditional anxieties also have impairing distinct anxieties. That is, for a third of autistic kids, traditional and distinct anxieties coexist. And finally, 15 to 17% of autistic youth have only a distinct anxiety presentation. That means depending on how we want to characterize those distinct anxieties, those fears as autism or anxiety, it could change our estimate of the rates of anxiety disorder in this population by 17%. We applied the same approach to better understand the anxiety presentations of autistic children who were treated in one of the largest RCTs of CBT to anxiety to date. And what we learned was that the vast majority of those kids met criteria for a traditional anxiety disorder. Only 2%, this is the light blue slice, had solely a distinct presentation. However, 50% of children meeting criteria for a traditional anxiety disorder also had interfering distinct fears. So what this means is that distinct anxieties may be very common in autistic children receiving CBT, even if they weren't the fears that got them into treatment. It also suggests that children with only distinct presentations may be less frequently recognized as experiencing anxiety and requiring anxiety treatment. Whether this holds true in a community setting requires further study, but these initial findings provide strong rationale for better understanding these fears, their role in autistic children's clinical presentation, and their expected treatment response. Research also suggests that carefully considering the presentation of anxiety disorders may shed light on how intellectual ability relates to anxiety and autism. In this study from 2020, we found similar rates of children with and without intellectual impairments presenting with impairing traditional and distinct anxieties. However, when we looked at the types of anxiety disorders being reported across groups, differences emerged. Specifically, the anxiety of children with intellectual impairments was primarily comprised of specific phobias, so things like fears of dogs, shots, the dentist, heights, and also of distinct anxieties. This is meaningful as it suggests that cognitive abilities are related to the expression of a child's anxiety, not the likelihood that they will have an anxiety disorder. It also is meaningful in that it offers some insight into why studies suggest that brief anxiety questionnaires, which have been developed and normed on non-autistic populations, have diminished accuracy in autistic youth. The traditional anxiety presentations that those measures screen for reflect just one part of the picture for autistic youth, a particularly small part for autistic youth with intellectual impairment. And finally, by taking the time to assess and differentiate traditional and distinct presentations of anxiety, we've also learned that they are associated with significant differences in the volume of the amygdala, the brain's fear processing center, albeit in disparate ways. Specifically, a recent study found youth with only traditional anxiety disorders had significantly larger amygdala volumes, which is the top red line, whereas those with only distinct anxiety had smaller amygdala volumes, the bottom purple line, relative to one another and to autistic children. Lee O'Connor wrote of Alfred in his original case series. He had a good deal of worrying. He frets when the bread is put in the oven to be made into toast and is afraid it will get burned and be hurt. He is upset when the sun sets. He is upset because the moon does not always appear in the sky at night. To address the challenge of anxiety and autism, we must begin by better recognizing and understanding the distinct expressions of anxiety. Thus far, our research suggests they are prevalent and impairing for autistic individuals. They are also likely under-recognized and under-treated in this population, and adding considerable variability to research, seeking to characterize not only anxiety and autism, but potentially autism itself, if not assessed. And that's it, but I do want to take a moment to say a big thanks to all of the families that participated in these many research studies, all the funders that have supported this work, and my many, many collaborators, colleagues, and mentors who helped me get to this point. Thank you.
Thanks, that was great. People often draw a connection between anxiety and the restricted repetitive behaviors. I'm wondering if you have any insight about that, and particularly about stimming also, and its use as maybe a way of dealing with anxiety?
Yeah, so I've certainly heard that qualitatively and from patients, and there are correlations in research studies between anxiety levels and repetitive behavior that I don't think are purely explained by an overlap of features, for example. So there does seem to be some connection, but I don't know if we fully understand what it means for each person. So for just clinically, in my experiences, some kids actually, repetitive behavior can be an expression of distress, that they are feeling very, very anxious. For other kids, it can be something that will help regulate and bring them down. For other kids, it might escalate. So I think there's a lot of variability there that we have to look into. Yeah.
Hi, thank you so much. Great presentation. I am an autistic adult myself, and I certainly have a lifetime's worth of experience with anxiety. I know it quite well. One of the examples you gave about the dog phobia, I also had a dog phobia as a child, and I can recall a specific incident where I was at a friend of my father's house, and he had these two big dogs, and I remember their names still, Breggins and Volton. And the guy thought it would be funny to kind of let them out of the gate that they were in because I was afraid of them, because I was afraid of the barking. And so this thing that was kind of a mild form of anxiety, it suddenly became much greater because it was amplified because of this man's actions. And similarly, when I was afraid of balloons because of the noise they would make when they would pop. My peers learned this, and they would chase me around with balloons till I would cry because they knew I was afraid. So have you looked at, in your research at all, at how these anxieties are exacerbated, you know, that there's something that may not have been a huge source, but then became much more so and rose to the point of being an anxiety disorder because of the actions of other people?
Yes. Do you want me to stay here? Yes, sorry. I just want to talk to you all. I think it's a great illustration of it's not just potentially, you know, an anxiety or an initial fear, but it's how people respond to it, and it's about the social climate. And I think that's actually a nice way to think about how interventions can be important and who they should be targeting, which is not just the individual who's experiencing the anxiety, but the people in that person's life, right? And that's true for folks on the spectrum, but also for just kids with anxiety disorders in general. You know, we're usually working with families and also with schools. And it's also a good way to differentiate thinking about what CBT is and what exposure therapy is, which is, for example, if you're afraid of water, exposure therapy is not pushing you into the pool. Exposure therapy is like dipping your toe in the pool and then being really excited about taking that step. And the person has to make that decision to face the fear on their own. And it's a really critical component of the therapy. So thank you. It's a really wonderful illustration that I think shows the complexity of why we need to pay attention to anxiety and what the person's experiencing, but also the life that that person is living and what kind of environment they're in.
Thank you.
Can you discuss catatonia, anxiety, and autism?
I wish I could. I will just flatly acknowledge that I do not have any knowledge about that at this point. Maybe it's a really important area for future research.
Okay, great. I didn't want to take someone's turn. Thank you so much for that. The questions that I have, you actually answered pretty much in your talk. But I wanted to address if you could further address the efficacy of the treatment for cognitive behavioral treatment in people with autism and anxiety, and the modifications that were made that you said for people with intellectual disability. Because in looking at both my professional experience and my personal experience with my daughter, who has severe anxiety, traditional CBT has not moved the needle, and she does not have an intellectual disability. So with autism and anxiety and those modifications without intellectual disability, just a little bit more to what does that actually look like, and what are your thoughts on what your research shows about best next steps or best practices for practitioners that are providing CBT to people with autism and anxiety?
Okay, I feel there's a lot of components there. I'm going to try and get all of them, but let me know if I don't. So the first question I think is about what are these adaptations and how much benefit do they offer? I would clump the adapted CBTs into two categories. One which is actually almost an expanded CBT program that's targeting treating anxiety skills as well as things that might go along with anxiety for folks on the spectrum. So you're not just treating social anxiety, you're trying to teach some social skills at the same time to deal with kind of the case I presented, right? Which is you don't just want to send somebody into a social situation being like, it's going to go great, when maybe it won't. So they target them together. Or thinking about behavior that the child may have that would prevent them from even participating in treatment. So for example, just some kids who get really anxious, the response is not flight, it's fight. Right? It's a big no. And so sometimes you need actually an expanded CBT protocol to kind of deal with some of those behaviors first to even get treatment going, right? So that's one. Another is, for example, the Facing Your Fears group program. Doesn't include many additional modules so much as it's just kind of adapted in terms of the way that you're teaching the skills. So trying to use more visuals, concrete language, interactive activities to make it more accessible for kids on the spectrum, or doing something which I think a lot of parents and siblings and people who know folks on the spectrum might do naturally, teaching the skills through a preferred interest, something that they're really passionate about, and using that as the entryway to say, how are we going to use this to face the things that are really hard for you? So those are the adapted programs. There's only one RCT so far that directly compares an adapted CBT to kind of traditional CBT, but it did show some benefits for the adapted CBT program, and in that case, it was Jeff Wood's program at UCLA, which is called BIACA, and now is available online for clinicians to learn through a program called Maya. In terms of how to teach providers out in the world how to do this, I think this is the complex next question, but it's actively being worked on in research, and I think it's what we need to do. I mean, the number one thing I think we need to do is to try and stop providers from saying, oh, you have autism, I can't help you. That is extremely stigmatizing, and I think in a lot of cases it's probably not true. But we also do need to hear providers and give them the skills to better support this population, or actually it will probably be a bad experience on both ends. And I've certainly heard that from folks on the spectrum. So there are some programs, though, as I discussed, like Jeff Wood's Maya program, which is actually putting all of the modules of the adapted CBT online with videos and making it available to clinicians to take themselves through a self-guided course and try it. So they're doing things like that. Judy Reaven is also trying her Facing Your Fears program in the schools. So teaching school providers to actually do it in the classroom to try and reach more children, and doing an effectiveness trial, which is less tightly controlled to see if it's actually going to work in the real world. So I think that's some of the progress that's going on. Yeah. Question up here. Okay.
Hi, thank you for your talk.
Yeah.
And I especially loved your the quotes, because they really tell a story that's very powerful. So I'm Shefali Jesse. I'm a child neurologist, and a lot of the kids I take care of and help manage have really profound autism and are often minimally verbal with severe intellectual disability. And parents often will come to us and to me and ask about anxiety and whether some of the severe behaviors or other challenges are rooted in anxiety. And it's hard to diagnose in kiddos who don't talk and have, severe ID. So I just wondered if you had thoughts on that. How do you think about diagnosing anxiety in that population? Sometimes, unfortunately, we empirically will treat to see if treatment for anxiety with medications will help some of the behaviors we're seeing, but that's a really, I'd say, kind of crude and messy way to make a diagnosis, but just wondered if you had thoughts on that.
Yeah, it's really, really challenging, but I will say in the 2020 study, we used this adapted clinical interview. We just did it with parents, so it wasn't youth and parent interview, it was just a parent interview. But we were able to get good diagnostic reliability, teaching clinicians to do this, and we've also done this with preschoolers with varied IQ to try and reliably assess traditional versus these distinct presentations of anxiety. And that was a pretty wide IQ range. It was from the Autism Phenome Project, which really tried to enroll the full spectrum of kids. The way we did that was a lot of training on the front end and what I like to call our mind meld, which is that I not only trained the clinicians, and we did a lot of practice interviews together, and we talked about what are we looking for and how do we do it. How do we do it is looking for a lot of behavioral examples, looking for a lot of what happens in this situation versus this situation, asking parents to tell us what makes you think that's anxiety. Can you tell us? Like, what are the possible cues of anxiety? What makes this different from, no, they just don't want to do it, in your mind? Like, tell us about that. And trying to really accumulate a lot of evidence to make the diagnosis. And just in general, I would say, for anybody who's worked with me on any of these studies, I actually try and be really conservative. So I try and say to clinicians, we're not going to give an additional diagnosis unless you really make the case. Like, I don't want to over-pathologize kids on the spectrum. Really give me some evidence that this is anxiety. And even doing that, people are able to kind of come up with these really clear behavioral examples. The parents will tell you, when he gets anxious, his face gets flushed, he like hides his face, she starts shaking. So we see a lot of kind of physical symptoms like that, even if you don't see a clear change in facial expression. So using an approach like that, and those interviews do take 3 to 4 hours. So, I mean, I think there's a question there about how replicable is that in a typical doctor's appointment. But on the research studies, when we do take the time to really do almost like a functional assessment, really asking about the behaviors, we've been able to get some reliability among clinicians and see some of the rates that I presented today.
Thank you. You mentioned the intersection of anxiety and autism and how anxiety doesn't necessarily show up as expected on assessment tools for folks on the spectrum. So do you have any recommendations for adapted tools or tools that would be able to target the anxiety in someone with autism?
Yes, there's been some improvement over the last decade. So Larry Scahill has developed a questionnaire. It's called the PRAS ASD, and it's a parent report measure of anxiety that was developed from mixed method work with parents of kids on the spectrum. It's supposed to be specifically tailored to this population. There's also a measure called the Ask ASD that was developed by Jackie Rogers in the UK, also specifically tailored to this population. And then the diagnostic interview that I've been talking about should be published by Oxford University Press. And I just want to say this is a disclosure as well. Know that I'm involved in this interview. Yeah, in the future, although that would need to be done by a clinician. So somebody with training kind of giving diagnosis. But we do have these new questionnaires that were, in contrast to what we had 10 years ago, actually tailored to this population. Okay. Thank you very much.